Hi, folks. I'm Dan Dworkis, and this is the Emergency Mind Podcast, a space where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. I'm so excited for this conversation. Our guest today is Dr. Angie Loza-Gomez, who is double board certified in emergency medicine and emergency medical services. She's an attending physician at Los Angeles General Medical Center, which is where I've been lucky enough to work with her clinically. And she's the EMS director in the Department of Emergency Medicine there. She's also the medical director for several municipal EMS agencies in Los Angeles County. Angie, thank you so much for coming on the podcast. We get these great conversations in the halls sometimes, and it's really fun to switch gears and have like a deeper focused thing here. So thank you for joining.
Thank you for having me, Dan. It's great to see you after, I think, a hiatus of seeing each other in those hallways. So I miss
Exactly.
you.
Yeah,
Yeah.
yeah, right on. Yeah, me too. So let's jump in. So it's an interesting balance of stuff that you work with. And maybe let's start by, could you give folks sort of an overview of like how you spend your time these days and like what falls in what bucket? Because I think where we're going to head with this is a conversation about how these different groups and different roles think through emergency processes. Maybe we'll see what happens.
Sure. Yeah. So I want to start off by saying that I really enjoy what I do. Every day is different. I work in the emergency department as I'm practically a clinician almost every day, it seems. And so I do see patients in the ER and I work with residents and I teach at the bedside and I provide a lot of teaching, didactics, modules, and so on. Additionally, I oversee the medical direction that occurs at our base station. And paramedics call into the base station at our hospital, and we then provide online medical control. So this is over the radio. And so I do oversee that process quite often as well. And so we listen to a lot of these audios for QI and QA purposes. And then I also oversee our EMS education for the residents and also our EMS fellowship. And so that's what I do on a day-to-day basis. And in addition, I work with fantastic group of people in the fire department, the EMS section, 911 dispatchers, and police departments. And I learn something every day. Truthfully, I am blessed and thankful for who I have around me. And so it's just a lot of fun and I grow and I learn every day. So
Awesome. Awesome. Such a thing to aspire to be able to answer the question that way. I love it. Can you drill a little bit into the work with the municipal EMS agencies? What's that shaped like, and what role do ER doctors play in that sphere?
it's a really good question. I think it's interesting to speak to other medical directors and learn about what they do. And it always varies depending on the needs of your department. And so really it depends if it's like we've talked about municipal versus fire-based, rural versus urban, long, short transports. And so it is really interesting that every medical director has a different role and every fire department EMS agency is different. For me in particular, I do a lot of quality improvement, quality assurance oversight. So I review a lot of the calls that our paramedics go on or EMTs go on, 911 dispatch calls as well. Any fallouts, any type of patient care problems that we encounter, I definitely am involved. I provide a lot of education, hands on simulation training, some didactics, but I try to do more hands on. And in addition, I do interface a lot with our hospitals for continuity of care, patient outcomes, and some administrative work that I don't necessarily love, but it has to be done and someone has to do
Sure.
it. So yeah, that's
Hmm.
essentially what I do.
So I want to press on two pieces of that. So one is the continuity with hospitals, because I think that's a story about how EMS services learn and get better. And then the other thing that I want to press on is you said the word fallouts, and I actually don't think that's a thing that's come up on the podcast yet. And I'm gonna fumble my way through an explanation, and then I'm gonna give it back to you so you can correct everything I just said. But my understanding is that for a lot of these groups, there are pre-established protocols about how to do a particular thing. So like, if you see this, here's your pre-established protocol, you will do X, Y, and Z. And then a fallout in quotes is the term that we would use if the operation takes a different course than what's prescribed by the protocol. And I'd really love to press on that, both in terms of like, how do you write the protocols? How do you figure out how to teach forward operating people to do emergency care, right? Because there's like sort of an existential question of a fixed protocol versus a variable universe, like will always produce variable results, right? That's like the motto of emergency medicine in general. So how do you design protocols that are robust enough to handle that, that help people get the job done as opposed to hamper them? And then I'm super fascinated like why we call it a fallout, right? Because it implies that there was a mistakes, maybe the wrong word, but we imply if you did what you said you did, it should go left, and instead we went right. And maybe that's a feature, not a bug, depending on how that works. Okay, so there's three questions in there. Pick any of the things. We can talk about protocols, about how EMS systems learn, or about like what do we do with a, in large quotes, fallout.
Yes, I'm gonna I'm gonna take a stab at it. In terms of protocols, the protocols are pretty straightforward and set forth by our local EMS agency, which is essentially our regulatory body. And so we, as all medical directors, meet together and perseverate and discuss these protocols. And so then we essentially produce a protocol that meets like the CHF provider impression, which is essentially a diagnosis, right? We can also create a protocol for cardiac arrest and when to terminate resuscitation and leave in the field and not transport as opposed to transporting these patients. So these are the type of protocols that we create locally, and every county has different protocols. They're similar, but there's nuances in how these are carried
Mhm.
out essentially. So these protocols are then taught to the paramedics and EMTs and definitely within their scope of practice. So for EMTs, they can only perform certain procedures. Paramedics can then perform obviously more advanced airways and IVs and so on and so forth. So these protocols are set forth pretty standard and so then they get then kind of essentially thrown out to these provider agencies and our job is really to make sure that they're learning what they need to do, the physiology, the understanding behind what is in these protocols. Then a fallout is when effectively the protocol is either misused or misunderstood or just not followed essentially. And moreover, that's a fallout for paramedics when it's a fallout in the medical control base station from our end, from our nurses and us as ER physicians when we get called to the base station. Those fallouts are a little bit more of standard of care where what is standard of care? Sometimes a hard question, right?
Sure.
Like the standard of care for an acute MI. Do we transport to a STEMI receiving center always? Do we divert because the patient's unstable? Do we stabilize in another hospital and then we transport to the STEMI receiving center? We just have to go based on what the standard of care would be and what would the average ER
Mhm.
EMS physician perform. So I think, and that one's a hard one a little bit more than the protocols that we have for our paramedics, which are pretty standardized. So
Why are there differences county to county between the protocols? Does it have to do with what's possible in the system or what is deemed legal by the legal bodies of the county? Because presumably the physiology is the same whether or not I'm in county A or county B.
gosh, that's a really good question, Dan. I wish I had an answer. It's one of our frustrations as medical directors.
Hmm.
Without going into too much of the regulation or regulatory bodies, California, we do have a regulatory body, and it even varies from state to state, believe it or not, in terms of scope of practice. But there is a national scope of practice for paramedics, which is more of the ceiling, right? This is the most you can do, and then every county sort of determines what is important to our community, what is important to our population, a little bit more specific to the needs of our transport times and so on. And so I think it varies for those reasons. And so you might go, for instance, in Central California where transport times are long. And therefore, the paramedics there might more aggressively intubate pediatric patients as opposed to LA County, where our transport times are really short. And so we focus more on more maybe a supraglottic airway, like an eye gel, for instance, or a BVM, and then focus on other things to stabilize the patient and transport that way. And for those reasons, the terrain, the transportation time, the mode of transport, it varies for those reasons, but the scope of the paramedic on a national level is the same. So it's pretty standardized that way.
We have some broad guidelines, which is how we expect paramedics to be trained in operating. And then we have more local criteria, like you're describing, about what's possible and what looks like in certain circumstances. And then bridging that in between, we have some sense of a protocol, which is here's how we expect things to operate in whatever normal circumstances look like. And then we have a fallout, which is that didn't happen for one reason or another. Am I level setting all of that stuff?
Yeah, that sounds about right. Yes.
Okay. And then I'm going to add one more. I'm going to add one more piece. And no, actually, no. Let's go this way with it. One of the things that's really interesting to me about that is that's very different. That structure, that thought process, is very different than how we say train ER doctors. right? So for ER doctors, we have a stance which is a lot more here is the general principle. Now, here are some tools we have. Now, let's see how you apply these tools to this principle. Or even you tell me what to do next and allow them to wander through space a little bit, which is it not quite the opposite of what we're describing here for the way that we're training paramedics, but quite different actually. So as somebody who trains both sets of people, like trains in one sense to use protocols to command and control is the wrong word, but to guide operations in a certain direction. And the other hand, training individuals who are supposed to be divergent creative thinkers and problem solvers. What does that look like to you? Like, how do you compare and contrast those methods of thinking and training? We're just going easy questions today. That's it.
Easy questions, not so
Yeah.
easy questions. I know. Oh my gosh. I think about that a lot, actually, because you're right. In the emergency medicine department or in the department that we work in clinically, we are pushing our residents, pushing ourselves to think outside the box, to think creatively. Obviously, with evidence-based medicine, we're not going to go cowboy, but at the same time, it just feels like we are using our critical skills, our creativity, our patient care skills, applying medical knowledge under pressure, and being able to maximize that as opposed to these protocols that are quite restrictive. In my mind, they're very restrictive to the paramedic and the EMT, where you get these phenomenal ideas from the field and they just can't perform it, even though they might be able to perform it quite well and possibly even better than us clinicians in the ER because of the circumstances that they find themselves in, low light, tough, restrictive situations where physically they can't get access to the airway very easily or the IV. And they maneuver themselves into these very stressful situations a lot better than many of us do. And so I'd say that they definitely have that advantage. However, they are pretty restrictive in their protocols. And so I do have to strike a balance between asking them to think outside the box and really pushing themselves to provide those skills that they would feel comfortable with. However, they're not technically allowed to do that because it's not within the protocol. I will say that when they
Mm.
call medical control our base hospital and we then get the ER physician on that phone call, we are able to expand on these skills a little bit more because again, the patient, like we talked about, the patient doesn't necessarily meet a particular box, right? Where the CHF patient is persistently hypotensive on BiPAP now. And so what do I do with that patient? Okay, let's give a little push dose of epi and let's think outside the box. And I'm allowing you to do that. It's still within your scope, but we're using that skill
Mhm.
for a different protocol this time. So I think medical control, base station, ER physician involvement in those situations are really helpful to really produce that the encouragement and the pathway for medics to really hone in on those skills that I'm confident they can perform. They're just not typically allowed to.
Yeah, absolutely. I have a distinct memory from working in a smaller hospital during COVID, and the protocol that was put in place by this hospital was that ER doctors would leave the ER and go intubate in the back of the ambulance for a sick person, and then bring the person in on a ventilator. And there were a lot of problems with that, like none of us had really figured out how to walk somebody across a parking lot on a ventilator, which is actually quite a complicated process if you've never done that before. And I learned firsthand how tricky it is to simply move the EMS stretcher the right way and not hurt the patient or the staff as you're doing it. But let alone like the skill you practice so many times, intubating becomes very different when you're intubating in a cramped condition on one knee down at a right angle because that's the only space that you're able to do it. And it's near transfer in the sense that it's still intubating, but it's also far transfer in the sense that like the situation and the construct around you matters so much to your ability to actually execute that skill set. So this model that we're poking at here, right? So our underlying the reason I'm so interested in this is because there's all these thoughts about how do you design the best possible systems to apply knowledge under pressure. And this is a wonderful example of one, right? We have variable things coming at us. We're not really sure what they look like. We have variable skill sets and trainings of our operators. And our method here is to produce a series of protocols that says, generally speaking, do XYZ. And there's a little escape valve on it almost, which is like, if you need extra help or you want other ideas, or maybe you have a great idea that you just want to push the envelope on, call this other person that can then expand your scope of practice in it. And that's what the base station structure of it is. And there's a whole skill set we can and probably should dive into as to how to be a good base station operator, which is how to give good direction on the receiving end of that call. But just to stay with this for another second, like philosophically, this is just a really interesting way of handling uncertainty. You're going to play a set number of structured cards, and then you're going to have the ability to go outside the rules of the game sometimes if you get extra support for it. I'm just wondering this out loud, but is this what you would build if you were given the reins from scratch?
Oh gosh, existential question galore.
We're not going to ask about what goes down the other. I want to get at like how would you reinvent education in general in medicine?
I would probably create protocols that are guidelines, not necessarily restrictive,
Mm.
and I would leave them a bit vague so that I would allow for some room for, certain skill sets to be applied like we talk about under pressure, or if you
Mhm.
have more time to think about a little bit of a thought process, discuss, call, and then decide as opposed to making critical decisions for immediate interventions that are life-saving. And so I would like to see a little bit more of ambiguity, if you will, because again, there's no one prescription for every patient. And so
Yeah.
I would say that some guidance and protocol is important, but leaving some leeway for these fantastic pre-hospital
Mhm.
providers is really the best option. And so I would leave it to them so then they can call in for the base station if they need help. And ER physicians can definitely learn from these paramedics where, hey, I
Absolutely.
oftentimes get on the radio and say, do you feel comfortable doing this? Do you feel comfortable leaving this patient on scene after this long AMA? We discussed benefits, risks. I'm really worried about this patient. And I know you are too, but we've reached the maximum intervention here and we will leave this patient or we will transport this patient. Do you feel comfortable giving Merced and sedating them a bit and putting them on 4-point restraints and bringing them to us? Is that okay with you? And oftentimes opening that dialogue, that
Sure.
communication with the medic it goes a long way. And I think it really sets the tone for empowering them to make those decisions because at the end of the day, they are interacting one-on-one with those patients.
Yeah,
Yeah.
absolutely. And as the base station in large quotes here expert, like you're very far removed from the problem set, right? Like you don't see the problem set the same way that your frontline folks are seeing that problem set. So it's a different sort of structure, it's a different sort of interface around that. I wonder, so and just I have this incredible memory of when I was training in residency, and you graduate to a point where you're able to do some of the medical control as a resident. And then they had us practice with folks who were paramedics who were off duty. They came in and did a exercise with us where they would have us talk through things and just be like, is that what you meant? Why did you say it that way? What is this teaching us? Like, how do you say the things that you need to say in order to actually transmit the information not just from a structural sense of radio etiquette or hey you it's me or how do you read me, all of that stuff, which is important, but also like when you have a limited bandwidth for communication, you don't have facial expression, you don't have body language, you just have these words that you're saying. How do you use them effectively to transmit like uncertainty and optionality and guidance without overbearingness, if that's a word, right? There's all those sort of wrinkles in there.
Absolutely. Absolutely. Communication is definitely something that I strive to be better at every day. And that is really where we get to the bottom of am I effectively relaying information that I want to relay? Am I using the right words? Am I being specific? And when systems will fail, especially for instance, MCIs or any critical incidents, it's communication that's going to fail. Whether it's nice to have redundancy, right? Where if this system fails and this then will kick in, but really having explicit words where we both understand the same terminology is really important. And like I said, I'm learning every day. This is definitely an art. It's a skill that I strive to become better at every day. Whether it be speaking to consultants, whether it be speaking to an EMT or paramedic, or speaking to a fire chief or police chief. You definitely have to choose different words for different situations.
Yeah.
But yeah, that's a tough one. I every day I wonder, am I communicating what I'm thinking? And so I really work hard on that.
But before we started the conversation here, you were telling me a little bit about how much you'd learned from some of your work with the police and tactical EMS teams. And I wonder if this is a good sort of segue branch point into that, right? We know from our colleagues in the military that training on communication and the structure of communication, the structure of not just communication, but the structure of transferring information as a skill set, which I understand that's somewhat the same as communication, but also a little bit different, is very well developed in the police and tactical side of stuff, in the military side of stuff, in a way that we're quite a bit, I would say, younger at it in emergency medicine on the civilian side. So can you poke at that a little bit? What's it been like working with the police and tactical EMS? What have you learned? Where are you growing that? And what could we be taking from that in the civilian ER side?
Yes, I have learned so much from the police department, the tactical EMS side of things. I will say that what I've learned from them, first and foremost, is what you've mentioned, their communication, their ability to type, if you will, a report or an encounter is phenomenal. They are 10 times better than I am at describing a person, describing situations. And so I really enjoy reading what they write and how they communicate over the radio, so on and so forth. And so that is one thing. The other thing I will say is that they always focus on mission driven scenarios where what is my mission? And I've learned to really incorporate that into team dynamics, one-on-one patient interactions. And as I'm teaching residents, I really want to focus on what is my mission. When we train on the EMS side and on the police side with, for instance, rescue task force, right, where there's a hostile environment, police have specific mission and they are phenomenal at focusing on that mission, where my mission is safety, right, to the public and to my team. And then the EMS side, the fire EMS side, medical side is duty to the patient. And so, really, what is your duty? What is your mission? Has really resonated with me. And I'm able to carry that anywhere I go, in particular in the clinical setting, in the ER. But the tactical EMS portion of what I do is something that I'm really fascinated by those tactics and how they're able to perform under those pressures and really focus on what they need to communicate and how they communicate and who they have their duty to. What is their mission? And it's quite different than what the medical environment is like, where our duty is to the patient and their, police's duty is to the and I've been involved in some task force committees here locally on the EMS, law enforcement co-response, if you will, for patients. For instance, if someone is combative, if someone is suicidal, for instance, or someone has a hostile environment, an active shooter, where how do we communicate with each other so that we establish our missions and we're clear with those missions and everyone understands their role has been a fascinating experience for me. And like I said, I'm truly grateful to work with them and under them. I'm their medical director, but I feel like I learned so much from them every day. And yeah,
Yeah.
that's been my experience.
So I
Yeah.
don't want to set up a false dichotomy here, but going back to our conversation a little bit ago about how we train ER doctors to think versus how we set up structures to guide paramedic thinking. Are you finding the tactical and police folks that you're working with, 'cause I don't know if this probably doesn't apply to everybody in general, but are you finding them training more like the medical school doctor model or more like the EMS paramedic model?
Probably the EMS paramedic model where it's very structured,
Hmm.
a little bit more restrictive, right? Not so much allowing for creativity, again, thinking outside the box, where they have very restrictive protocols and standard operating procedures, SOPs. So everything is fixed. And that is very much a first responder, pre hospital, 911 dispatch philosophy. And so for us in medical school, we do learn a lot of fixed physiology, pathophys, right? Pharmacology, and that's pretty fixed. But in the clinical setting, I think we do push for, again, thinking outside the box, critical thinking. And so I think it's two different schools of thought.
Yeah.
I'm trying to find a way to meld both where I can teach better communication and a little bit more structure and protocol driven in many ways in the ER, but at the same time allow for our EMS providers to be creative and to really hone in on those skills. That inner crossability or that interface between both is something that I try. I'm really
Yeah.
trying on. It's a little tough, but yeah.
No, absolutely. And it's super important to just point this out as a clarification thing. None of what we're saying is that there's a good model and a bad model. right? All of these models of thinking and training and learning and operating have strengths and weaknesses. The creative, sort of more flexible model is really good at finding weird solutions to things and coming up with efforts that'll change the scope of stuff. But standard operating procedures save lives, right? They exist because they save lives, especially at the beginning when uncertainty is high and when information is low and when skills aren't necessarily as sharp, right? So if you could, if you gave me a super creative thinking intern versus an intern that knew their standard operating procedures, I'll pick that second one almost every time in the emergency department because what I need them to do is put their hand on the bleeding and stop it. Do a jaw thrust, roll the patient to recovery position. I don't need a 60-page exposition on the new theory of genetics that they're working on, right? Eventually, maybe we need that, and that's awesome. But what we need is the basics first and then sort of movement. And even that's wrong because I'm setting that up like a linear progression, like you do the basics and then you do the creative stuff. And I don't actually think that's true. I think it's much more of a balance. And I don't know, the image I get here sometimes between like creative and more structured thinking is, I'm gonna get, this is gonna be super esoteric. I'm sorry in advance, but like the yin yang symbol, right? How there's the white part and the black part, but there's a dot of the white and the black, and there's a dot of the black and the white, right? That nothing's perfect. Like you have a kernel of creative thinking within the algorithms and a kernel of algorithmic thinking is within the creativity part. So none of this is like good or bad. This is just different systems of thinking. And now I'm gonna get off my esoteric bandwagon here for a second. As you were describing, like the struggle to teach both of those things. Tell me more about that. Like, how are you thinking about it? What have you found that works in teaching the balance of those two systems of thought? Maybe even what doesn't work? Like, how are you approaching that?
Yeah, it's a really good question. So I have found that instead of me projecting ideas or starting off with the question why, I oftentimes just have them tell me what they're thinking. Tell me what your thought process was. And that really gets the tone as a very sort of safe space. I'm not here to be critical. I'm here to understand your thought process, and I will learn from you as you will learn from me. So it's just like a not necessarily a monologue, but a bi-directional sort of conversation of what went well, what could have gone better. And I oftentimes find that it just relaxes the setting and everyone is opens their ears and eyes and just really is able to absorb information in multiple ways. And so I find that's helpful. And then I'm able to then learn from what they were thinking, why they did certain things, and so on and so forth. And so I think that really helps. What I find really challenging is when there is a critical incident, and we do this a lot, again, with 911 dispatchers, EMS, and even in the emergency department, where we have a critical incident and we want to debrief. We want to have like a critical incident review. And so then we're able to open the floor for those who want to come forward and say what their experience was. I think again, that's a little bit different in that we have a hot wash or some type of debrief thereafter. But as I'm teaching, as I see some, critical actions that could have gone better, I find myself thinking, is this the right time to talk about this as opposed to we just resuscitated a pediatric cardiac arrest, we pronounced baby dead 10 minutes ago. I'm not so sure
Yeah,
it's the right time to talk about this. So
totally.
yeah. So I struggle with the timeliness of it. And oftentimes when I do feel it's time, when I feel sort of I'm trying to read the room and I feel like it's an okay time to discuss this, I do start off with like really open-ended questions and I want to just have people say what they saw, what they experienced. And so I think that works really well across the board from police
Mm.
to EMS to 911 to residents to faculty, nurses, respiratory therapists, multiple multidisciplinary services. And so I find that's really helpful.
We've been working this project recently that talks about like layer cake style debriefing, right? Where every event gets this base layer, which is some version of are we okay? Did anybody get hurt? How do we regenerate the ability to respond quickly? And is there any crucial lesson we learned that absolutely has to be changed for us to operate again? So, can we restock the code cart? Is our piece of equipment broken and it needs to be fixed? Whatever it is, just are we okay? And then most things get this second tier, which is what just happened, right? Which is like a sense making version of it. And it's really not trying to derive reusable lessons or do an M&M or whatever it is. It's really just what just happened? Let's get the different viewpoints of the room together and try to tell the story of what we think just went on and try to make some sense out of it, which is what you're saying. Like, okay, tell me what your thought process was here. Not was it right or was it wrong, but just like what happened and do we understand it? Because as the leader or anybody in the room, you never have the whole story about what went on, right? You don't know all the points of view. You don't know all the situations of it. And what you gave earlier about what is the right thing to do for an airway being totally dependent on the nature of transport, the barriers to getting to a hospital and all this stuff is a great example, right? So seeing, well, tell me about what it was that made you make that decision. How did you understand the world when you chose to do blah, blah, blah? Right. And then some stuff on top of that gets that third layer, which is more like a traditional M&M or a safety to driven or a root cause analysis or something where you're like, all right, what do we learn from this? Like what needs to change as a whole? Or should we rebuild training based on this? Should we change the protocol? Should we whatever? But that layer kick style is super important because you're right. There are times when like nobody in the room is prepared to have a deep dive discussion about the physiology of should we give this drug or that drug if we're all dealing with the fact that this child just died and we have to sort of like have to slash get to be human beings about it. Yeah, I like the way you're describing that. Just where are we, what happened, and tell me what you were thinking. How did you understand the world when this was going on?
Yeah. And we have different walks of life, right? Where I could have been thinking of, God, I don't know, I could have been thinking of my own child, right? Or I
Sure.
could have been thinking of my own grandpa or grandma that just passed
Mm-hmm.
away yesterday. And so I think really understanding and having this concept of just culture where I think we're getting better in the hospital but we're working really hard in the EMS environment to have this concept of open communication, understanding that everyone's accountable again for their mission, their role, and we are all trying to do our best. However, there are going to be near misses. There's going to be medical errors. Did I give the right medication to the right patient, the right time, the right, route? And so I think having this, again, the concept of just culture is really important. And it's, again, important for us to dive into that at a time when we're all open to discussing these situations. For instance, if again, going back to the pediatric cardiac arrest, if we talk about this culture of accountability, we're all accountable for our actions. However, we did our best. Our procedural skills were spot on, and babies still died. Patient outcome was still not what we intended, not what we hoped for, but I think that if we all think about our own steps and near misses, or gosh, I really made a huge mistake, right? I had a needle stick, for instance. I left the guide wire in central
Yeah.
line. Those are big deals. And I think having that open communication where let's look at our system. How do we fail you? How can we do better as a system is really important. So I think really having this concept transcend beyond the emergency department into again, going back to our process of care prior to the hospital, where our EMTs, our paramedics, our police who applied a tourniquet, for instance, or our 911 dispatcher who provided instructions for that chest compression for that baby. These processes of care for cardiac arrest occurred way before we saw them in the ER. And how do we then create this culture of excellence with the just culture? I think it's a really an important concept that I think I work really hard to instill in my systems.
Can you can you define just culture in this case?
Sure, yeah. So it just culture is a system where you have an open communication for processes of care, and again, everyone involved is accountable for their role, for their mission in that process. And so we have this open communication where we can discuss near misses, positives, negatives, strengths, benefits, risks, and we then look at our system to see how we can improve. Did we not provide the appropriate training for this, first day EM who then dropped the patient on the in the stretcher because we didn't teach him that there are some safety locks? Did we not provide him the appropriate use for appropriate needle sharps container? And it's little things like that that we can look at our system and say, okay, how can we understand how the system can do better as opposed to pointing fingers and making it an individual problem. And so making it less punitive and more of a communication dialogue as how can we do better? to help the system and the individual healthcare provider do better and maximize their ability to provide patient care in an excellent way.
I love it. Thank you for laying that structure out. I think that's an incredibly important lens to look at what we're doing this with. I think we've barely scratched the surface on all this stuff, right? We drifted into philosophy and systems and everything else, but I want to be mindful of our time here in a moment and give you a chance to offer a challenge to folks who are listening to this about anything we talked about today or about anything you're wrestling with in general. While you're thinking about what that challenge is, I'm going to stall for you for a second and just put our disclaimer in here, which is that our goal here on the Emergency Mind Project is to capture the best of what other folks already understand about applying knowledge under pressure and disseminate that out to the world. We don't provide medical advice, and none of us are representing any of the people we work with or for. We're just representing ourselves as we're out here trying to make the world a better place. So, with that, Angie, what do you want to leave folks with, and what do you want to challenge them with?
Sure. Yeah. I actually have two challenges here that I've thought about. One of them is, what is your mission?
Mhm.
Right? When you're in a leadership position, when you're part of a team, when you're communicating, what is your mission? What is your role and how will you deliver that? With the second challenge is, how will you communicate that?
Mhm.
Are you using the verbiage, the terminology that people understand? Are you clear with that? And I think that if we apply those two concepts and challenges to our everyday sort of life and interactions with teams and patients, I think we're better people for that.
I love it. Angie, thank you so much for coming on the podcast. Thank you for what you're doing and for pushing the edge of all of this. And just thank you.
Thank you, Danny. It was really nice to see you and be here and share my ideas with your community.